on behalf of Kara Tannenbaum and the rest of the steering committee, welcome you to this talk with Dr. Carrie Bourassa. The floor is yours.
Great. Oh, good God, sorry. I'm gonna have to get my daughter to take the dogs. Sorry, I thought she had them. 1 second, apologies. Lily, come and get the dogs. I don't know why your sister doesn't have them.
Okay.
I think that we've all done Zoom calls now with our dogs going off in the background.
I just got off a 4-hour Zoom and they were good, but there they are. Apologies. That's Forrest and Cooper. Okay. So thank you for indulging me. So I know we don't have a lot of time, so I'll just start with introducing myself. So I'm Carrie Bourassa. I'm the Scientific Director of the Institute of Indigenous Peoples Health at CIHR. And I'm originally from Treaty 4 territory. I'm a professor in the College of Medicine, the Department of Community Health and Epidemiology. And you can see I have a lab, Morningstar Lodge. It was originally a Canada Foundation for Innovation grant, and we developed that at the direction of community who we serve. I've done community-based work serving Indigenous communities for over 20 years now, and yeah, so I'm really excited to be asked to be here today and share a little bit of work around CanCOVID. And Dr. Jeff Redding is and remains a mentor of mine, and we're really happy that he's on the governance committee for CanCOVID. I'm a co-lead along with a postdoctoral student from our lab, which is Carrie McElduff. If you want to flip it. Thanks. So I won't spend too much time on land acknowledgement, just to say that I'm in Treaty 6 territory right now. My institute, the Institute of Indigenous Peoples Health, is in Saskatoon, but very aware that I am in Treaty 6 and I'm Treaty 4 territory. I am Anishinaabe Métis, and very grateful for the warm welcome that I have in Treaty 6 territory. So I've done a lot of work around cultural safety long before I think cultural safety sort of became a bit of a buzzword. And I wanted to talk a little bit about that. And cultural safety is not sort of just about health care, but it really is about a lot of pathways. And we do a lot of work with communities around dementia, for example. And we do a lot of work around cultural safety and thinking about culturally safe pathways, for example. So I want to share a little bit about this today. So thinking about practicing cultural safety is really about many things. And so with COVID-19, when this hit our communities, the communities that we work with, the communities that we serve, the first thing that we heard about was that communities did not have accurate information, access to accurate information. The information that they did have access to was, I would say, very clinical, very wordy. Even when we were reading some of the information as academics, we were like, what the heck? I mean, we couldn't, we couldn't figure some of it out, and so. Certainly we had to respond to the needs of the community and what we were hearing from community. And so we wanted to create culturally safe, culturally sensitive information, and that is part of cultural safety. So we also were seeing a lot of information that was deficit focused. We do not undertake deficit focused research. We think about strengths-based approach, asset-based approaches, and so that's what culturally safety is, right? It's about thinking about the resilience and the strengths that we have in our communities. And so what we came up with was protecting our home fires. There's a lot to unpack in that, because our home fire was where we were safe. We tended our home, we tended our fire, right? We tended our fire traditionally. So that's what we came up with, was protecting our home fires. And we did 2 fact sheets, which I'll show you in a few minutes. And they were focused less on wordiness and more on photos, on pictures of so that if you saw the visual of it, you would understand, oh, okay, yes, this is what we mean. And you can see in the back here a picture of our bundle, which we take into the sweat lodge every year, and you can see that you can connect to that immediately. So cultural safety, what is it? It actually is about power. It's not really about culture at all. And it's about addressing institutional discrimination, bias, sexism, racism, and of course, colonization. It requires that researchers actually establish trusting and lasting relationships. And I just see a note from Harlan saying homophobia. Yes, absolutely, homophobia. And it is ensuring that we empower communities and promote self-determination. And if you've heard me speak before, then you will know that the Indigenous health research in Canada, the Indigenous health research agenda in Canada must be led by Indigenous communities. And so we just take direction from communities, and what communities want us to do, we fulfill that as best we can. So in relation to COVID-19, the medical community has to incorporate cultural safety into all practices, whether it's research, whether it's diagnosis, whether it's treatment. And patients or clients come first. If you want to flip it, you can. So why is cultural safety so important during COVID-19? Well, we knew when this hit that, of course, again, Indigenous communities are going to be marginalized, and we're seeing this. So cultural safety, I just have to move this. Cultural safety was developed originally by non-dominant Maori people, particularly nurses, reacting again to very negative experiences within the healthcare and nursing system. So we need cultural safety because it requires an examination of our personal biases about systemic racism, so authority within healthcare systems, about privilege, and the territorial history that can influence the relationships between healthcare providers and Indigenous peoples. So you have to really do a lot of self-reflection, both as practitioners and researchers, and that critical reflection of the research questions and the involvement of the community, the true engagement, the true involvement, that communities really are leading the research, and patients or clients, they are in charge of their healthcare or their healthcare plan. If you want to flip it, you can. What does it actually look like? So despite the name, as I said, it is not about culture, right? It is about power, and it's about power inequities at the core. So the decision about whether a clinical encounter between a client and a clinician is safe lies with the Indigenous client, not with the physician or the clinician or the nurse or they actually have the power. Victoria! My God, sorry, I apologize. So it is really not about, it is not about the researchers, it's not about the doctors, it is always about Indigenous communities or the Indigenous patient. If you can flip it, please. So what does cultural safety look like during COVID-19? So during this crisis, it's imperative that cultural safety takes us beyond cultural awareness and the acknowledgement of differences between cultures, and it surpasses cultural sensitivity it surpasses cultural sensitivity. Sorry, I got to get these dogs up here. It surpasses cultural sensitivity with, cultural safety actually encompasses cultural awareness, cultural sensitivity, all of it. So you don't have to sort of piecemeal any of this. So it goes beyond that acknowledgement of differences between cultures. It encompasses the recognition and importance of respecting difference. And it understands that limitation of cultural competence that really only focuses on skills, knowledge, and attitudes of practitioners. And one major limitation of cultural competence is the reduction of culture into skills for which practitioners can gain knowledge. So if you use a cultural safety, you are embedding all of those other activities within. So cultural safe resources addressing COVID-19 for communities are imperative. Engaging OCAP principles, for example, which are ownership, control, access, and possession of data and specimens, and also inclusive of Tri-Council. But I want to be clear that while we always include the Tri-Council policy statement, we are very aware that these do not go far enough. The Tri-Council policy statement, they only provide really suggestions. They'll say, well, we suggest that you have a research agreement with communities, but OCAP really takes it much further. And OCAP is really, really about self-determination. When you talk about ownership, control, access, and possession of data, we're talking about self-determination. We are talking about self-governance. That is the step much further. And so, I think it is really important to think about that. Not only has First Nations developed these protocols, but other communities are developing them as well. Some First Nations are developing and adapting their own protocols. We know that the Inuit Tapwrit Kanatami is developing their own protocols, and the Métis Nation, the Métis National Council is also developing, and it's in their infancy, but they are developing their protocols. If you want to flip it. So these are the fact sheets that we developed. This fact sheet, and we have All Nations Hope Network, Virtual Hospice, the Canadian Virtual Hospice, and Les Filles de Madeleine, which is a Métis women's community organization. But this was a fact sheet we developed, and this was more for clinicians and academics. Certainly, communities still found this to be very helpful, but this was not ideally for communities. This was more for communities. Now, this one we found to be, what we heard was very helpful. We had clinicians who sent this to their partners in Portugal, in Guatemala, even to partners in Alaska. So if you want to flip. Now this one, for example, was really, really taken up in community. And we have translated both of these resources into many Indigenous languages. We also translated it into French because the Health Canada, Indigenous Services Canada, the Saskatchewan Health Authority, PHAC, Public Health Agency of Canada, and many others have been ecstatic to have these resources. And so on the right is a Nakota translation. We have translated into Cree, Dene, and Michif is coming out right away. And we have Lakota coming out as well, and Dakota as well. So we have almost all of the languages in Saskatchewan that will be translated, and now we are getting requests for other languages. We have a Soto coming right away as well. And we languages across Canada now being requested. But we want those requests to come to us. We don't want to step on anybody else's toes, so to speak, outside of our territory. Maori have also taken this up, and they're translating it into Maori. So we are getting a huge uptake for the protecting our home fires. We have videos on our website, and we try to make them a little bit fun, so they're not so sterile. But definitely there's been huge uptake for these as well. If you want to flip it, Kimberly. Health, in terms of healthcare and cultural safety, again, healthcare providers are encouraged really to engage with clients, but not only clients, because again, we don't really think in an individual manner. Family members and communities are very appropriate, and it's difficult in the age of COVID, right? We just got a request from the Saskatchewan Health Authority, a rapid, it's called a rapid assessment, asking when people are alone and you can only have one visitor, how is this going to affect Indigenous communities? Well, there's going to be a huge effect, because when somebody is palliative or very, very ill, it's extremely important to have their family around and to be able to have elders there and have people praying around them and having their loved ones there. What matters most to them, in their experience of illness and treatment, isn't only, that actual healthcare provider, but it is what else can be provided. Is the spiritual aspects, the prayers, the food that can often be taken, and now during COVID-19 that is not happening. So when healthcare providers engage with clients in a good way, it can really present opportunities to ensure it's Indigenous client focused, and all of that has sort of stopped in the era of COVID-19. But culturally safe care does require building that trust with Indigenous clients, recognizing the role of socioeconomic conditions, our shared history, particularly including obviously colonization and politics in health, and communicating that respect for clients' beliefs, behaviors, values, and ensure that the client is a partner in the decision making. So these are aspects that are imperative in the wake of COVID-19, that you can't lose sight of that, simply because now we are in a pandemic. More than ever, these are very, very important for clinicians to understand. Sorry, if you want to flip it. So I'm almost done now. But what do Indigenous communities need moving forward? I can't stress this enough, but the mobilization of Indigenous self-determination. We need more Indigenous physicians. I know this is obviously a long-term need, but healthcare providers, clinicians, and researchers, we need, we hear this in almost every study that has been published, that yes, of course, allies are very important, but Indigenous peoples want to see Indigenous physicians. They want to see Indigenous healthcare providers, clinicians, and researchers. Culturally safe allied physicians, again, are important. And as I said, we need all of them as well. We need to work together. We're all here on Turtle Island together, and they need to be appropriately trained. And this includes the tough topics that most people don't want to hear about: white privilege, systemic racism, discrimination, bias, homophobia, as Harlan pointed out. And more research is really needed to document those poor health outcomes and that are related to racism. And I have heard it, and I continue to hear. I continue to hear people say that racism is not connected to poor health, and that is incorrect. Racism is definitely a determinant of health. And so stereotyping that is faced by Indigenous communities that need culturally safe interventions. So really, we need to develop culturally safe models of care for health services that are offered to Indigenous peoples, regardless of location. So I think I only have one slide here left. sorry, I can't seem to move this here. Oh, can you just flip back a bit? I think yeah. So the last slide here is that really for the desired outcomes of cultural safety in COVID-19, we have to value and acknowledge the expertise and skills of elders and knowledge keepers, and develop partnerships and collaborations with Indigenous communities and organizations, and challenge privilege and practice for self-reflection, allies and champions to practice being culturally safe, ensure that research and theory is translated into policy at all levels, and believe me that we're not very good at this, unfortunately, so we have a lot of work to do there. And I hear from community, we need pandemic preparedness. And that is something that we have to really, really continue to work on. But communities need to take the lead on that, and then we have to find ways to make this happen and not wait. What we're hearing is that we have to start now. So I'll leave it there, and thank you for indulging me. I apologize for my puppies. Miigwech.
Thank you so much. Thank you so much, Carrie. I think we're already at time, so I understand anybody that needs to leave, but I just wanted to note that in the chat there was some lovely compliments for your fact sheets and people saying that they've used them and they've been
there's a girl offering sex for Big Macs in your parking?
I can't hear what's happening there, but I just wanted to say, so thank you for sharing those sheets. There was a question about data collection. Is it more or less consistent with cultural safety? Is qualitative research to the safety that you're after?
So I think qualitative research is probably closer in terms of cultural safety, but I think that data collection is very important, and we have to create ways to ensure that it is culturally safe. And there are ways to do that, and I think it's just a matter of us creating and developing research methods that are culturally safe. And there's some really good work. I mean, the First Nations Information Governance Center does incredible work, and I think it's just a matter of using both, because you can't just use one method and say, oh well, this is the culturally safe method. You know, we have to sort of dispel those myths that you cannot undertake quantitative work, and we're hearing from communities right now that they want to be involved in serosurveillance studies. They want to be involved in the vaccine studies, because we have to be counted. So I think we are now on the cusp of a new era, and we need to embrace that, but be taking direction from communities.
And one last question before we totally run way over time. Somebody's asking about where do urban Indigenous people find themselves? How do we ensure the safety of our urban Indigenous service providers and their urban Indigenous clients?
Well, exactly. I think that this is the thing, is we have very, very diverse communities, and we have to meet their needs. And this is why Indigenous communities across Canada, they need to be in the driver's seat to be able to say, this is where we're at, this is what we need, and find the partners that they need in order to move forward. And you know, from an IPH perspective, we need to know what their needs are in terms of research, so we can put out the appropriate opportunities, so that they can lead their own research, find their own partners. But if we don't know what the needs are, then we're not putting out the appropriate funding opportunities, then I mean, we can only do so much at CIHR. But I think collectively, their needs as urban communities are going to be different from the needs of, on reserve communities or northern communities. And so I think that's really important for us to know. And we certainly do our best to work with, communities across Canada, and I use community broadly, so that we can try and make sure that needs are met.
And one last question, just because I know I just said the last one was last, but this is because somebody said they think it's important to mention. How do you see the new NEIHR networks being involved?
Oh, the NEIRs are going to be phenomenal. We have absolutely excellent NPIs and teams, And I have no doubt that it's going to transform the landscape in Canada. Absolutely 100%.
That's fantastic, and I love ending on a positive note. As Carrie mentioned, she is one of the co-moderators of the Indigenous research channel in the CanCOVID Slacks. If you are not a member, please go to cancovid.ca to register. And if you are on the Slack channel, please find this conversation and more on the Indigenous research channel.